very happy to welcome our speaker, Jamila Michener. Jamila is an assistant professor in the government department at Cornell, and she writes on poverty, race, public policy, and she is the author of Fragmented Democracy, Medicaid, Federalism and Unequal Politics, and she's going to talk to us about her book today. She has written numerous articles as well as her book on issues related to healthcare and participation. She also has a fantastic new project on access to civil representation in different metropolitan areas. Jamila also is a communicator of her work to public audiences, and so she has written op-eds in the New York Times, the Washington Post, Vox. She is the co-leader of the Scholar Strategy Network, which is for the Finger Lakes, which is an organization that brings scholars together to communicate to the public more broadly. So Jamila is both a fantastic scholar as well as a public communicator. And for those of you who are on Twitter, she has a Twitter handle, there it is, Poverty Scholar, that I highly recommend. And if you want to see any of her writing for the public, you can go to her website, and you can click through to those. So today she's going to talk to us for about 35 minutes, and then we will have 20 minutes for questions and discussion. So thank you so much for being here, and the floor is yours.
Thanks for that introduction. I appreciate it. And there are not many introductions that mention your Twitter handle. So funny, I'm always on the fence about whether Twitter is an entire and complete waste of time or whether there's some value to it. So now, you know, one tally in the column of value. Anyway, thank you all for coming. I appreciate this. I love this room, first of all. It's so bright, and then I love the fact that it feels like there are just enough people that you have an audience, but not so many that it's overwhelming. I can actually look at you all, make eye contact. So I'm really happy to be here. I've told several people I appreciate the opportunity to talk about the book. One of the things that happens once you publish the book, people are like, well, why talk about it anymore? Nothing we say here will matter. It's already in print. And that's not true for a lot of reasons. One of the reasons is because engaging around the work helps me to continue thinking about questions that continue to be important to me and that continue to animate my research agenda. I'm working on a few projects right now related to health policy and Medicaid. The kind of policy realm that I focus on is quickly changing, right? And there are always new things coming up. And so it's useful for me to remain kind of in conversation. And so I want you all to feel like, this is an opportunity for me to share about my work, but in the conversation that we have that follows, it's also an opportunity for me to kind of think with you and learn from you in ways that are productive for me and that I hope can be productive for you. So I'm going to approach this as kind of just talking you through my research process, and along the way, you'll find out what the book is about. There's the book, which you see there, and this is like obligatory. So on a lot of talks that I've been giving that are not about the book, that are about new work that I'm doing now, this is still always my first slide. Because those of you who are graduate students who may be working on dissertations, you spend years working on something, and then at least in the case of my dissertation, like my instinct was as soon as I was done to like hide it somewhere and hope nobody ever looked at it again. And I still hope that. Whenever people are like, I found your dissertation, I'm like, no, please don't say that. But with this, I think you're supposed to do the opposite, which is be happy that it exists out there and try to encourage folks to look at it and read it. And actually, so the book is sitting around my house, and I didn't realize that my kids had got a hold of it, and they think it's really cool. My name's on the book, but all of it, the last 2 weeks, my kids have just started saying, Medicaid cuts kill. My 5-year-old said this to me about 2 weeks ago. He said, Mom, Medicaid cuts kill. And I thought, where did you get that from? Your book. So think carefully about the cover of your book, because it may influence the next generation. Okay, so I'm going to start with Mabel, just to give you a sense of kind of where this research came from. So I didn't start off as a graduate student like, I think I want to write a book about Medicaid, or really I think I want to write a book about anything. What I knew was that I knew what I cared about, and I knew what I came to graduate school to study and to think about. And that was about politics in communities that were on the economic and racial margins, in low-income communities, occupied predominantly by Black and Latino folks. And I wanted to understand what politics meant to those folks and how their lives kind of came into contact with the state through policy. And I wanted to think through those processes. So as many people are in graduate school, you know, there's this moment where you've taken all your exams and there's nothing really left to do besides write something, write a dissertation. And I had all of these big, like, I'm interested in political agency and poor communities. And, you know, my advisors were like, you really need to find a way to narrow this down. And I sat down and I talked with Mario Small, who was a sociologist on my dissertation committee. And he said, well, you know, you could just go read some literature and decide what gap there is and focus on filling a gap in the literature. You could pluck something out of the thin air or just be responsive to what's on the news. All of those things would be fine. But, you know, he knew me well enough to know you really want your research to be motivated by what's happening in people's lives. And so why don't you find out what's happening in people's lives? You have a sense of the broad kind of areas that you're interested in, but you need a specific question. Why not let the communities that you're interested in studying guide that specific question? And so I started to talk to and have pretty open-ended, these initially pretty unstructured interviews with people on the south and west sides of Chicago, because I was at University of Chicago at the time, so that's where I was, that's where I did the interviews. And I asked them questions about what mattered in their lives, what was important, how they understood government and politics and the role of that in their lives. And I probably had like 5 or 6 questions initially, just really broad questions to spark conversation. One of them, which one of my dissertation advisors had suggested and I was skeptical of at first, I asked people what they think about the American dream. I thought, what is that? Like, what am I gonna, I have no idea what I'm gonna get. You don't ask a question, you have no idea what you're gonna get. But, you know, with qualitative research, you do some of that because it allows people to tell you things that you hadn't thought you wanted to know. So I asked a woman named Mabel, who was an African-American woman in her early 60s who lived on the south side of Chicago. I met her outside of an unemployment office on it was a day like this, it was kind of rainy afternoon. And I said, well, you know, would you talk to me for a few minutes? I'm doing some research, not out here in the rain. And so we went to a nearby McDonald's and we just sat down and we talked. And one of the first things I asked her was, what do you think about the American dream? Like, how does that figure into your life? And this is what she said. Mabel sighed a lot. She sighed all throughout the interview. So in my interview transcripts for her, it's like sigh, sigh, loud sigh. And she said, I don't know anything about the American dream. The American nightmare is still a fact. I have to go to a doctor every 3 months. I have to have pills every day. Sometimes you have to choose between medicine and food. And then she mentioned Medicaid, just in passing. And she said, I went there, but it was just so much, I left. And, you know, at the time, I wasn't thinking about Medicaid per se, but in the conversation that I had with her, this choice between medical resources, between medicine and other things like food or housing or whatever, came up again and again. And when I asked her about politics and like whether it meant anything to her, whether it gave her or people like her any leverage for addressing the struggles that she brought up, she said, look, I need to go and stand in somebody's line and get some medical help. So I had moved on from medical anything. I never brought it up in the first place. She did, right? But I wasn't there in the interview anymore. I was asking her something different. I was asking her about politics. But she goes back to, look, I gotta stand in somebody's line to get medical help. So when you ask me about the government, I say, I don't know what's going on there. I don't approve. I'm sure there's something we can do like vote. It's supposed to be making a difference if you vote, and it did make a difference in November. She's referring to Obama's election. That was early 2010, so she was talking about the 2008 election. But we vote for everything else, and we don't get it. And so this was, you know, the first interview that I had, and I had a series of interviews after. It wasn't the first one, but it was one of the first ones. And I had a series of interviews after that during the time that I was in graduate school that when I asked people about what was important to them, healthcare was coming up. And many of the folks that I talked to, because they were living in poverty, when they brought up healthcare, they also brought up Medicaid. And so I started to think about Medicaid as something important that I might want to study. I actually avoided Medicaid for the most part in my dissertation. I only had one chapter on it. I felt like it was a kind of labyrinth of a program that you needed to know a lot about in order to be able to do good research, and I just didn't feel like I wanted to pay those startup costs at the point that I was writing the dissertation. But when I finished the dissertation and I looked back at it, that one chapter that I had was the chapter that I liked the most. It was the place that I thought I could really build, and so I was lucky enough to have a 2-year postdoc, and I started to think a lot about Medicaid and how, as a program, it gave me leverage for thinking about the things that I really cared about, right? So where I live, right, the intersections that I live at as a scholar are kind of these intersections between race and class and public policy, right? And Medicaid really was a way for me to think about and talk about those things that I care deeply about. So 90% of non-elderly Medicaid beneficiaries are either poor, meaning they're below the poverty line, or low income, meaning that they're within, they're at 125% of the poverty line or below, right? And 50% of beneficiaries are Black or Latino, right? Which is not proportional to their representation in the population. And so I thought, this is a public policy that has significant implications for the communities and the populations that I care to learn more about. And so I was convinced that I needed to think more about Medicaid, and I wanted to understand how it mattered politically, what it meant for democratic citizenship in the communities that I wanted to learn more about. And so this was, initially I thought about this kind of pretty straightforwardly as a policy feedback question, and it is a policy feedback question. And the policy feedback literature says that policy creates politics, right? And so we know that the other way around is true, and the kind of the intervention of that literature is to say that, okay, but policy shapes the way that people understand their interests, it shapes the resources that they have access to, it shapes the way that they interpret government, and ultimately affects their political behavior. And so I thought, okay, we don't really know how Medicaid fits into this picture. It's not exactly straightforward. It's a means-tested program, and so we may expect that it would have a negative kind of feedback effect. But it's also a really popular program. It's also a program that serves lots of pretty sympathetic populations, children, folks who are disabled, elderly folks. So I initially started with this basic question of, well, what's the relationship between Medicaid enrollment and political participation, right? And I thought of it as a policy feedback question. So for data or evidence to kind of address this question, I turned to the Fragile Families and Child Well-Being study. And in part, I turned to this study because it's kind of a big survey. They follow a cohort of 5,000 children, but also their parents, so the mothers, the fathers, right? And they're following them over time. I'm actually only able to use one wave because that's when they ask about political participation. But the core thing is they're trying to identify families that they understand to be fragile. And so there are a lot of people in the survey who are living in poverty, which also means that there are many Medicaid beneficiaries. So 53% of people surveyed in the survey are Medicaid beneficiaries, that is not what you find if you look at GSS data or ANES data or pretty much any other data. I've examined a lot of the patterns that I'll show you now in other data sets that are more traditional data sets. The adolescent, the Ad Health data set from UNC, the GSS, et cetera, and the results are always the same. But Fragile Families gives me the most leverage because I have a large N of Medicaid beneficiaries and non-beneficiaries who are also from fragile families, right, who are similar in many ways economically. So when I take my kind of initial cut at this data and I'm just looking at correlations, this is pretty early on in the project, not surprisingly, it looks like there's some kind of correlation between Medicaid enrollment and voting, right? So, and other forms of political participation, registering to vote. There's a kind of scale that I have that's just participation outside of voting, that thinks about whether or not you were a member of a political group, whether or not you participated in a demonstration, things like that, so that we can think about participation more broadly insofar as the survey allows us to. And for each of these outcomes, non-beneficiaries participate more than beneficiaries. Now, of course, this could be for a lot of reasons, and the most obvious reasons have to do with the fact that those folks are different in some ways that matter. They're more disadvantaged economically, they may be more likely to have health problems, et cetera, et cetera. So, my next step is to try to develop an analysis strategy that helps me to account for as many of those potential confounders as possible, so that I can be sure that whatever relationship it looks like I'm seeing between Medicaid enrollment and political participation is actually a relationship that's actually because of Medicaid and not because of other things that I'm just not accounting for. So I have this kind of like 4-tier analysis strategy in chapter 4 in the book, and I'm not going to go super deep into this stuff because we only have so much time and I'm trying to cover as much ground as possible, but I'm happy to talk about it more. The idea is to kind of start with a standard regression where you control for a bunch of things and you try to understand whether Medicaid enrollment, and I think about either the parent being enrolled or the child being enrolled. Because when your child is enrolled in Medicaid, you still have to interface with the system. You're still experiencing the policy vicariously through that. I'm trying to understand that as the kind of variable of interest and how it affects the outcomes that I'm interested in around voting, registering, and participating, while controlling for a range of other things that we think would matter too, right? And then I expand the models to incorporate controls that might be especially relevant for the kind of fragile families and low-income communities that I'm interested in. So things like drug and alcohol dependence, depression, experience with incarceration, et cetera, et cetera. Many of those things turn out to be really important in my models, but they don't change that core relationship, that core negative relationship between Medicaid enrollment and political participation. And then I try matching, which is, on a number of variables, I make it such that my group of beneficiaries and non-beneficiaries look as similar as possible, right? And so it's not experimental, but it's quasi-experimental. It's trying to approach that without being able to do experiments. And just as an aside, there was actually a Medicaid experiment in Oregon where they had extra funds and they decided they wanted to give some subset of state residents Medicaid, but they didn't have enough funds to give it to everyone, right? And so they did it by lottery, and they worked with a number of scholars who've used that as a way to try to take advantage of that randomization to understand the effects of Medicaid. I've asked them to let me see that data before, and they haven't. So it's not that I haven't tried. But anyway, we'll see that that wouldn't have worked for me anyway. And then seemingly unrelated regression, which is the kind of basic logic behind that, and like I said, I won't go too deep into the weeds here. The basic logic behind that is to try to estimate two kind of models at the same time. So one, which is what some of these other methods are doing, is accounting for the relationship between Medicaid enrollment and political participation. But the other is simultaneously accounting for what accounts for whether people enroll in Medicaid in the first place. This way we can be a little bit more confident that, that the confounding isn't coming from the fact that there's something different about the people who have Medicaid. There's something different about, even when we both are eligible and we're both similar in many other ways, maybe the kind of person that actually signs up is different in some way. And so we model whether or not people sign up for the program in the first place at the same time that we model the relationship that we're interested in, to try to make sure that the kind of the error that might exist by not accounting for whether or not people enroll is addressed in some way. None of these things mean that my results are dispositive, right? None of them eliminate the possibility that there's something else going on that I'm just not picking up on, right? And I don't have anything that's like a neat experiment, and so that's just a limitation. So I'm gonna fly through these results really quickly. In every model, I see the same basic pattern, and the basic pattern is a negative relationship between various political outcomes and being enrolled in Medicaid, right? The size of the coefficient, so the size of the effect changes, and the kind of error around that effect changes based on which of these modeling approaches that I use. But the basic relationship holds, right? And so we can talk about the kind of pros and cons and interpretations of these later if folks are interested in it. But the idea is we can do a lot of different kinds of statistical wrangling, and it seems like there's a negative relationship between Medicaid and political participation. So that's where I got by the time I was at the end of graduate school, and I'm giving talks and I'm presenting this research, and people are saying, well, I don't quite get why, right? What's going on here? What are the mechanisms? And I had a vague sense of that, but I really didn't know, and I needed to do more qualitative work in order to figure out how people are understanding their relationship to the state vis-a-vis Medicaid as a program, and why that would be shaping political outcomes, why that would be determining how they engage as democratic citizenship. So I kind of turned, once I was doing a postdoc, to a kind of qualitative research, which I had the time then to do. And I did 61 in-depth interviews with beneficiaries and folks that I call stakeholders, who are people who work closely with beneficiaries and could corroborate, but from a different perspective, or complement, but from a different perspective, their understanding of the world. So application assisters who help Medicaid beneficiaries to sign up for benefits, attorneys who represent them in public, in courts, in administrative hearings when they lose their benefits, and those sorts of folks who are stakeholders who are closely connected to Medicaid beneficiaries and have a sense of their experiences, but from a different vantage point. Because many people will say things like, this is not, I don't espouse this view, but a lot of people approach qualitative research and say, well, how can you believe what people tell you when they tell you about their experiences? Maybe they have reason to want to paint themselves as victims or want you to feel like they've had negative experiences or what have you. The benefit of talking to stakeholders is that you're talking to folks who have a different set of incentives, right, who are positioned, located differentially within the kind of institutions that I'm thinking about here with respect to the policy, but who can still speak to what's going on, right? I focused on range in terms of race, in terms of categorical group, meaning some Medicaid beneficiaries are disabled, some are elderly, some are just adults who are working and who just make very low income, and others are adults who have children who are ill, etc. I try to get range across those categorical groups and geographic context. Initially, I didn't realize how important geographic context would be, but I knew it would matter. And my goal was both to try to make sense of the quantitative patterns and to generate and develop new hypotheses, right? I wanted to use qualitative research, people's experiences, to help me understand what was going on here, right? So from these interviews, there's initially a broad story that I kind of expect emerges. And that story is the story that we hear in other feedback studies, for example, around cash assistance. And it's about stigma, and it's about negative interactions with bureaucrats, right? And I'm asking people about their experiences with Medicaid, and they're talking about embarrassment, and they're even sometimes using the words negative stigma. They're telling me what they feel like. This is what I feel like. I feel like shit. I feel like I'm nothing. Because when you're in Medicaid, they do whatever. You have to be on their rules, right? So this is helping me in some way to make sense of the reasons why, you know, the kind of interpretive mechanisms here. This is changing the way that people are affecting the way that people think about government and relate to government and understand the role of government in their lives. And people explain lots of negative bureaucratic interactions. Interestingly, you know, there are folks who explain these negative bureaucratic interactions who are not living in poverty, right? So about a little over 60% of the Medicaid beneficiaries that I interviewed are people who are poor. But I also wanted to interview some who weren't. So Chris is a middle-class woman who is a nurse practitioner, who's like the head nurse at a nursing home. And when she has her youngest son, her fourth child, he's born with severe, severe health problems, severe disabilities that mean he will always need extensive medical intervention. And they tell her within the first few days of his life that in order to keep him alive, it's going to cost millions of dollars a year. And they say, we know you have insurance, but it's not going to cut it. We're getting you signed up for Medicaid. And so she begins her journey with Medicaid. Her and all the rest of her family members have regular, traditional insurance. And so one of the things that's important about some of the middle-class folks that I interview is that it's striking how similar their experiences are. Because some people will say, well, any set of poor people you interview will say this stuff. They're experiencing stigma everywhere. That's just part of being poor. That's not about Medicaid. But that's not true. Because even middle-class folks who are living relatively comfortable lives like Chris are experiencing very similar things. There are differences that are important that I get at in the book, but it's also worth pointing out the similarities. Katrina is another person who's actually a college student who comes from a middle-class family, but she just happened to get pregnant after her first year in college and needed her son covered via Medicaid, and so has all these experiences with the program. So there's the broad story, stigma, negative interactions with the bureaucracy. But then there were unexpected narratives that emerged that opened my eyes to the possibility of other processes here. So I interviewed Terry in Georgia on a warm August day, and all I said was, tell me about your experiences with Medicaid. That's what I want to know about. And these are the very first words out of her mouth. My name is Terry, and I have a 16-year-old son. He'll be 17 soon. I've traveled a lot. So the difference between state to state with Medicaid and what it offers and the programs and how consistent they are, I have a lot of experience with that. Being in Medicaid 17 years, you know, it has just been a whirlwind with keeping, she said his name, but my son safe and healthy. And so this is when I start to think about what it might mean that Medicaid is as fragmented as it is across states, across places. And Terry had details. Ohio is the easiest. They care about their people. California, it's fast, but there's too many people. It's rapid. It's out of control. In Georgia, everything's limited. Where you can only go to this doctor on that day at that time, right? And she could go through every state she'd lived in and the nature of the program there. And she told me, this is the point in the interview where she got really emotional. She said, you know, when I knew I was going to meet you, and all she knew was that I was somebody who wanted to talk to her about Medicaid. I'd met her the day before on the street outside of a Medicaid office that I was just hanging out at, seeing who would be willing to schedule interviews with me. And a lot of people were. And then those people suggested friends to me that they knew were on Medicaid, so I could get people who maybe wouldn't have been as willing, and so on and so forth. But so she had just met me the day before. She knew we were going to meet and talk about Medicaid, and she's thinking about it. And she's like, I got a lot to say about Medicaid. My grandmother was here from Chicago just this past week. She goes to the hospital, they tell her she needs a prescription. Well, Medicaid in Illinois doesn't cover the prescription in Georgia. So they can't get the medication. And she said, that was amazing. And for something that's provided by the government, you're limiting the use of something that's meant to make people better, right? And Terry knows it's political, right? She says if it was about helping people, you would say, yes, let my state be more productive and healthy so we don't have people losing their lives. She knows that the state is making a choice. And because the state's interest isn't truly in helping people, they're making the choice to not have this benefit available across borders, right? And I asked Terry, what do you think that you or folks like you could do about this, right? I'm trying to get a sense of, do you have any sense of power to intervene here? She stares at me and she just goes, white noise. I have no idea what that means, but I think that silence is productive in qualitative interviews. You don't try to fill every single space with talking. I talk a lot, but I try to hold back. And so I just looked at her for a little while. She just looked at me. And I said, okay, what does that mean? You know? And she said, white noise is the people that choose to say, people like her, right? That choose to say, well, if they give it to me, they give it to me. If they don't, they don't. White noise means you feel like in your world you have no say in the process if you don't agree with what's going on in Medicaid. It's the needing, the process. I've never really seen anyone stand up about Medicaid. I don't know why we don't fight. And so Terry has these contextually differentiated experiences that she makes sense of through political lenses and that she uses to draw conclusions about engaging, about who engages and why, and about her place in the polity, right? And she wasn't the only one. This comes up again and again the more people that I interview. John is another person. So John was a middle-aged white man, and it was great because it was actually much more challenging for me to recruit white Medicaid beneficiaries who just, when I face-to-face, went up to them, just were not interested in talking to me. And there are just fewer men on Medicaid, so that was harder to find. So I went out of my way to find these folks, and I end up, through a research assistant, I had a research assistant who recruited John, and I'm interviewing him, and he looks totally fine, and he's just this middle-aged white guy. I'm thinking, why is he on Medicaid? And it turns out he has a chronic illness, that it's an issue with both his lungs and his digestive system, and just, he's had it since childhood, he's been on Medicaid since he was a kid, and it's been challenging for him. And recently, a few of his friends and family members moved to Arizona. He talked to his doctors. His doctors say, actually, given your lung condition, if you move to a drier climate like Arizona, you probably would have a better quality of life. So he wants to move. But he does his homework before he moves because he knows Medicaid keeps him alive. And the Arizona Medicaid, which is called quite instructively the Arizona Healthcare Cost Containment System. That is the name of the Medicaid program. There's nothing, anyway, the title of the program suggests what they're about, right? Not helping you be healthier, containing cost. And, you know, he checks it out, he finds some folks that he knows there, and he realizes that if he goes there, there are some crucial benefits he needs that he won't be able to get, right? Periodically, for example, John needs to use a feeding tube when his digestive issues are just too much. And in Arizona, there's limits literally on how many feeding tubes you can get a year, how often your nurse can change your feeding tubes, things that when he starts looking into the kind of nitty-gritty, realizes I could die because of some of this stuff. So he's not moving to Arizona, even though his wife wants to go, his family members and friends have gone, and he says, I'm not where I want to be. But beggars can't be choosers. I try to tell myself, I'll live on Mars if I have to. You know, you're just going to do what you have to do, and it's not very fun, but okay. Unless something changes to, you know, where I can, if they did like a federal insurance and everybody had an insurance card regardless of who we are, where you are, I think it would solve a lot of problems for people. But I don't think that's going to happen. Being a man and being older, just knowing you're never going to better yourself, in that sense, it's been hard seeing other family and friends and they're able to move on. It's tough. It's hard. I mean, I've accepted it a long time ago because it's what he has to accept. And he says, I feel like, you know, I have a wife, but I'm really married to Michigan medically, right? And so I start to get these narratives that are very much about place, and it sensitizes me to kind of thinking more broadly about the kind of contribution that I want to make theoretically, right? When I think about our kind of models of political participation, we have the traditional models that may come from, you know, kind of Verba, et al., Rosenstone and Hanson, and they tell us that there are lots of things that matter, you know, individual characteristics like age, socioeconomic status, etc. But then also kind of meso-level institutions that mobilize people, right? That get you to come into politics, parties, interest groups, organizations, places of worship, and they affect the extent to which people engage and ultimately their political participation. Policy feedback intervention is to say, wait, public policy is a part of that process. It kind of imbues a set of experiences that also affect the way that people engage, the way they understand policy, their levels of advocacy, etc. And those things also affect participation. And then there are contextual models of participation, which I thought about as people like Terry started to tell me about place. And that says, you know, context matters too. And these are additive. That's why there are plus signs. All of these are part of a larger process that's shaping political outcomes, participatory outcomes. And part of what I decided that I wanted to do in the book as kind of important intervention was to think about these things together, right? And so I developed what I call the contextualized feedback model of participation, right? And so public policy, institutions, meso-level institutions like parties, interest groups, organizations, and then individual characteristics, all these things are embedded in context, state, county, neighborhood context, right? And they're affecting political, which I think of capacity as sort of engagement that is contextualized. They're affecting political capacity, right? Your interest, your kind of your interpretation, your way of viewing politics, resources, a whole set of other things, right? And ultimately affecting political participation. They're operating together, right? But they're all also affected by macro institutions like federalism, right? Which shape the nature and contours of public policy, which structure the activities of meso-level institutions, and which are meaningful even with respect to helping people to interpret and understand the role of individual characteristics like race and ethnicity, right? So part of what I'm trying to do is understand all of these things and how they operate together to influence political outcomes. So once I start to get the idea that context really matters, I go back to the Fragile Families data, and now I'm interested in looking at whether I see different patterns across states, right? And for the 15 states in that data for which I have enough kind of subgroups within a state to be able to do within state analyses, I want to understand, do we see this negative relationship between Medicaid enrollment and political participation everywhere, or do we see it only in certain places? And what I find is we see it only in certain places. In New York, California, Virginia, and remember, these are the only 15 states that were in the data that I could do this for, so it could be in other places that I just couldn't measure this way. There's a negative, so below that red line, negative relationship between Medicaid enrollment and political participation, like I said before. All the states that cross the red line, it appears that there's no relationship, at least as far as this data can show us. And then Wisconsin is just above the line, meaning a positive relationship. It's worth keeping in mind that this data is circa 2003, 2004, so maybe we don't think of Wisconsin is not a leader right now when it comes to Medicaid. Wisconsin is not doing well. But Wisconsin was doing very differently in the early to mid 2000s, right? And so there are differences across places. Part of what I want to think through is why, right? Why do state policy contexts matter? How do state policy contexts matter? And I can just decide I'm going to pluck this out of the thin air, but I go back to my interviews and I look at the ways that people reference and talk about context when they're talking about their experiences with Medicaid, right? Often they're talking about expansions or retractions, right? The policy is changing, making it hard for pretty much anyone to go to a doctor, just to get a general PAP or any kind of exam, right? And this is a woman in Michigan who's like, you know, last year 2 years ago I went to the doctor and I got a PAP, it was no problem. This year I go and it's like hard. They don't cover that anymore. And that kind of retraction, right? Or even when it's an expansion. But when you can be given and it can be taken away, and that's fluctuating over time, that really strikes people, right? They understand that there's a kind of arbitrariness to this program and capriciousness. The scope of services, people were very aware of what they could and could not get, right? So people would say, well, you know, there are two plans we can choose. We can choose a plan where we can get dental but no vision, and we can choose a plan where we get vision and no dental. You know, we have good teeth but bad eyes. So people are strategizing in that way about their family's needs, which makes them very aware of the scope of services, right? Oh, I needed physical therapy, but it's not covered. I needed a hearing aid. In some states, you're an able-bodied adult, you need a hearing aid, you're on Medicaid, you're not getting the hearing aid, right? The range of things, right down to hospice care, right? From birth right down to death, there are things that you may not be able to get based on very specific characteristics that beneficiaries surprise me with the level of detail and awareness. They're not just moseying around having no idea what they can have access to. They know very well. And so they're sensitive to the scope of services. And administrative capacity. Again and again, people talked about too many people, not enough workers, right? And in some states, not as much as in other states, right? And this idea that when the bureaucrats, the frontline bureaucrats are overworked because there are too many of us and too few of them, the interactions don't go up, right? So these are some of the state policy contextual features that I hypothesize based on the interviews matter. And when I go back to the data and I find kind of contextual data that measures these features, and I try to see, do these things help explain, right? Do we see that Medicaid beneficiaries in states that, so this is now just looking at beneficiaries, right? Not trying to understand beneficiaries versus non-beneficiaries, but trying to understand just among beneficiaries, do beneficiaries that live in states that have different characteristics behave differently than their counterpart beneficiaries? And so all of these things matter, but in different ways for different outcomes. The most kind of clear and consistent effect is for benefit reduction. So for participation, for voting, for registering, when benefits have been reduced, right? When the previous year in your state there was some kind of reduction in benefits, that's where we see that Medicaid beneficiaries are least likely to participate. This is just another way of looking at that variable specifically. Scope of services matters, but it seems to matter specifically for voting, not for the other factors. Benefit expansions matter for participation, the kind of broad category, and also for registering to vote. So, you know, it's a smattering what matters for which outcome. But those state policy factors are significant, especially reductions. So especially when things are taken away from people, which makes sense, right? I want to round things out because I've been talking for a long time, but just for the last few minutes, I want to make sure that I clarify. I look beyond states in the book, and the reason I look beyond states is because when people are telling me about their experiences, they're not just talking about things on the state level. Often they are, And that was sort of the first level of analysis that kind of jumped out to me. But I was struck again and again by people talking, not just about states, but talking about counties. I moved from this county to that county, and my experiences with the program suddenly changed. And then in people I interviewed in cities, talking about their neighborhoods, right? Talking about the difference, for example, between living in the suburbs and living in the city proper, or even the difference between what you experience given what neighborhood you live in. Oh yeah, because of where I live, the place I go to get my Medicaid is that clinic up at the street. Often people would call local clinics Medicaid clinics, right? Like Medicaid doesn't run clinics, right? But they understand the clinics to be Medicaid clinics. So when that clinic is on a block that is dangerous, that you know someone got robbed last week, and on your way to that clinic, you're passing people who are shooting up, and you go into the building and the building is falling apart, you associate Medicaid with all of the other features of decay and deprivation in your life. And so many of those folks who were experiencing and utilizing Medicaid in places that had kind of marks of urban decay talked about the program and viewed the program in completely different ways than other folks, right? So when I look at counties, I focus on county bureaucratic structures, and I look at a different outcomes, which is appeal processes. I wanted to think about not just traditional forms of political behavior, but when Medicaid beneficiaries encounter a problem, do they do anything about it, right? I talk about a woman in the book named Shanna, who her husband was suddenly required to pay this huge, they called it spend down, before they would allow him to qualify. And the spend down was like $400 a month. They're a low-income family, they can't pay it. So he just doesn't have Medicaid, but he has epilepsy. Stops taking his medication, starts having seizures. He bites off 3/4 of his tongue because he has a seizure. And they end up going to the emergency room, getting it taken care of there. And I said to Shanna, like, oh my gosh, did you appeal his Medicaid denial? No, why would I appeal? And she told me about other times she had appealed, but just not this time. And I wanted to understand, okay, once we're outside of the realm of voting and things that may seem far away to beneficiaries, and we're in this realm of what I call particularistic resistance, pushing back against government decisions that have a direct impact on your life. What happens? And what I find is that that's where county-level bureaucratic structures affect these processes, right? And people told me about, maybe I'll do a hearing, but it's going to take a long time. And by the time I get to the hearing, I'm probably not going to need what I needed before. And I look at both Florida and New York and try to understand, how do states that have counties embedded with them, how does that multi-level interaction affect whether or not people engage in appeals processes? And I also pay attention to the neighborhood context and how that matters, right? I talk about a woman named Daphne who says, it's Medicaid is like, it just, what you get depends on where you live, right? It's like if you're at an Olive Garden or at a Burger King. And if you're in the hood, you get Burger King version Medicaid. If you live in a nice neighborhood, you get Olive Garden, which to Daphne's very fancy restaurant, version Medicaid. And she talks me through all the details of how this is all about what neighborhood you live in. And so I turn to some quantitative analysis in Chicago neighborhoods and find that people who live in neighborhoods that they perceive as disorderly, right, those are the places where we see that Medicaid to politics negative link. And in other places where that is not how people perceive their neighborhoods, the link isn't there. So in context, whether it's at the state level, the county level, or the neighborhood level, right, affect a range of outcomes from voting and registering to vote to more particularistic forms of resistance to very local forms of political engagement, right? And this holds across policy actors. Towards the end of the book, I pay attention to policy advocates and activists. They can make a big difference, I argue. They are deeply connected and engaged, and so they have a wide reach. And federalism matters for that. Fragmentation weakens their advocacy often. It makes it difficult for them to hold political leaders accountable, to mobilize across states, and to represent beneficiaries who even within states have so many different interests, right? And so some of the broad takeaways, Medicaid has differential political effects across states, counties, and even neighborhoods. But even more broader than that, federalism structures the relationship between policy and polity in a way that we need to kind of confront and contend with as scholars. Federalism's not the problem. It's not a problem. It's the institutional structure we operate in within. It's a vehicle through which politics operates. And one of the things that it can do, that it can facilitate, is political inequality, right? And so whether political scientists, policymakers, activists, we have to keep the kind of democratic consequences and implications of federalism in mind when we're engaging in discourse and research and ultimately in decision making. I probably went over time. I'll stop there. Thank you.
We have some time for questions, and maybe we'll collect a few and then let you answer. So, Anthony?
Just real quick, this is about Arizona. So the short synonym for the cost containment system is, if you know, this is access.
Yeah.
And so the interesting thing is that
I never mentioned that part. I see that as a euphemism, but anyway.
Well, it's because it's shorthand in the state, and the entire idea is that in Arizona, they say they actually have a very expansive Medicaid system because it's supposed to include people who live above the poverty line, which is something that was passed by voters back in the early aughts. And so, and this kind of gets to my question. So you have two things. You have scope, the scope of services, but is there also relationship between scope of who's included, like percent of population or place on the poverty line? How does that influence voting behavior as well?
Do you think that the Clinton welfare reform revisions exacerbated the Medicaid problem or issue?
Thanks. On the point of the federalism structure being a vehicle, then it sort of immediately pushed me to think, to what extent do the citizens get to turn the wheel here, right? And I wonder how you think about this overarching federal context as a structure that constrains citizen action versus how accessible it is to allow citizen action.
I'll let you go. All right, so the first question, I think that's a great question. So I don't kind of show all the variables and all the models because it's overwhelming, but I do think about and account for eligibility, right? And so the scope of the services, but also the scope of the program, who counts, who doesn't. One of the reasons why, so eligibility doesn't emerge as much in the models, and in the qualitative data, I get a sense of why, which is, so when people aren't eligible, they don't actually, I didn't get a lot of anger about people not being eligible. Beneficiaries go through periods where they're eligible, they're not eligible, they're eligible, they're not eligible. And when I ask them how they feel about that on-off, they're like, well, they gotta make decisions and you're not always gonna be able to be eligible, and that's fine, Where they got up in arms is when they're eligible, but then they can't get the services they need. So you say I'm eligible for this healthcare program, my teeth are rotting and I can't get dental care? That is much more kind of enervating for beneficiaries than if you just tell me I'm not eligible. If you tell me I'm not eligible, look, I'll try to find other ways of making this happen. But once you say I'm eligible and I actually deserve this benefit, then you say, but you can't get this and you can't get that. And so eligibility and scope of services factor differently in the minds of beneficiaries, which is why I think we don't see the same kind of effects with regard to something like eligibility, which is structuring the scope of the program more broadly, but we do with respect to scope of services. Scope of services impinges in a really direct way in people's lives that kind of hits on their sense of fairness, right? Anyway, there's more there that we could talk about, but I'll try to be judicious. So, Clinton welfare reform. I don't know the answer to this question. It's not a question that there's kind of empirical data in the book that lends itself to asking or to answering. But I certainly have a sense of it. I think a couple things. I think that welfare reform set off a dangerous precedent with respect to Medicaid. So first of all, one thing that's important is that in many places, Medicaid and TANF are linked, right? It's the same organization, the same building that you're going into, the same caseworkers that are providing. Now, there are many, many fewer people getting TANF than there are getting Medicaid, many, many fewer people. But people also know that's the building you go in to get welfare. So to the extent that on the ground, welfare in terms of cash assistance and Medicaid in terms of medical assistance in many people's minds are closely linked, then by stigmatizing welfare and saying that welfare as we knew it was something that needed to end, something that needed to have work requirements attached to it, time limits, et cetera, there is a kind of a risk of also indirectly stigmatizing Medicaid. I think in a lot of ways that doesn't really come to fruition, right? It doesn't necessarily happen quickly, but I think it lays out a strategy that Republicans have slowly tried to work, right? And now that strategy, now those chickens are coming home to roost. And we're talking about Medicaid now in some of the same terms we were talking about TANF and cash assistance in the 1990s. And so now, in some states, we have Medicaid work requirements. There are states that are proposing and trying to have time limits. There are states like Wisconsin that proposed but recently got rebuffed even by this administration that wanted to have something akin to or approaching drug testing. And so a lot of that is like the rhetoric and the kind of orientation that we have long had towards cash assistance is being carried over towards Medicaid now. What I call the kind of welfareization of Medicaid. And ultimately, like, the long-term strategy is eroding the program. So certainly I think that what happened with welfare reform in the 90s has a long-term implications that's not structuring what's going on with Medicaid now.
And that's why I asked you, I think that the issue is that if you're ahistorical, when you're looking at Medicaid, it's problematic.
Yeah, I agree. I agree. So there's a chapter in the book where I think about the kind of history of both anti-poverty policy and of healthcare policy more broadly, and these things aren't coming out of a vacuum. We've been building this house essentially since the beginning, since before the beginning, right? Before we were even the United States.
Let me get one last question in, and then you can answer
sure.
these. You
I
can
promise
answer
to.
Matthews and then Marion. Did you raise your? Did you want to ask a question?
Okay, do it now?
Yes, do it now.
Hi.
Hi.
I watched this woman last night in Georgia. She wanted to expand Medicaid. Is that
Stacey
right?
Abrams,
Yeah,
right?
that's her name,
Yeah.
Stacey Abrams. How does that fit with? How will you advise her? Given, I think you were saying this sort of dampens, this would have a problem.
Yeah. Okay.
So
this
how
is
will
great.
you tell her? Sit her down and say, okay, you're going to expand this, but there's political implication of this. You would tell her what? Would you tell her?
Well, so I would tell her two things, right? One is that there's research that's been done in the last 2 years that actually suggests that Medicaid expansions are a boon for political participation. And that doesn't, I don't view that research as being in conflict with what I find in the book for two reasons. One is, this is exactly what I find, is that the relationship between Medicaid becomes kind of like a bust for participation when the program is retracting, when it's retrenching, when people are getting less, when they're associating with having things taken away. But when Medicaid is generous, right, when the program is expanding, when people are having positive experiences associated with it, because now they can get things they couldn't have before, it does the opposite. So Jake Hasselworth at the University of Michigan and Clinton and Sanses, I don't remember them, Michael Sanses and Joshua Clinton, they have an APSR piece that came out just a few months ago that shows Medicaid expansion is actually leading to boons in political participation. So I would tell Stacey Abrams, yes, go for it, but be careful, because people will originally respond positively to gaining a benefit. But if then their actual experience of the benefit is negative, that can turn into a negative effect down the road. And so for the states that say we're going to expand, but we're going to attach work requirements, and we're going to make sure there's a lot of bureaucratic red tape, we're going to make people's lives hard. So you're going to get this health insurance, but we're going to make your life hard along the way. The long-term effects of that can be a dampening of the kind of political engagement.
Based on your research. Based on your, right?
Yeah, based on my research. So I would say in the short term, Stacey Abrams, yay, this is going to get people out to vote. In the long term, if we don't pay attention to the experiences people are having and the way the program is structured, it can have a very different effect. Yeah. But real quick, I'll return because I know I didn't get to you, and I'll just say, I think that I try hard to think this way in the book because a lot of people say, oh, you're just, ho-hum, like, federalism is horrible. How is that productive? Federalism is what we have. And is federalism all bad? So we thought federalism was horrible. So maybe I thought as I was writing the book, most of the book, it was the Obama administration. So maybe then I could say, oh, federalism is horrible. We want the reins in the center, right? Once Trump takes over, a lot of people are like, thank God for federalism. And so it's worth remembering that like it goes both ways. So if we think about federalism as a vehicle, the question is there a way you can steer it positively? And in the last chapter where I look at policy advocates and activists, I show some ways that they try to leverage federalism to their benefit. It provides them with examples. They can find states where things happen that they don't want to happen where they live, and that motivates them, it gets them fired up, it lets them fire up other people. They can find states where great things happen, and that gives them a model, and they model after that. And they also use federalism, some of the ambiguities of federalism to their advantage at times as well. And when they recognize that federalism is a thing, they mobilize strategically because of it, right? So it's not like it's all bad, and it's not like actors are just passively like affected by it and not trying to actively use it to their advantage. Although on the net, what I find in the book is that it's not working. Federalism is not working for ordinary people right now. I see a two fingers, so does that?
Yeah, I mean, my take home would be maybe not federalism, but underfunded, targeted programs delegated to states that stigmatize populations is the problem.
Yeah, so I mean, I think so. Part of the reason why that structure for programs is possible is because of federalism. So I think it has larger implications. But I take your point that it's important not to paint with too broad of a brush, because federalism does a lot in our political system in a lot of different places. And in some of those places, this analysis isn't going to apply, right? So I think that's right in that sense.
But I was wondering, I mean, you don't talk about the difference between a universal and a targeted program, and there's a large literature on that, and I was wondering why you didn't reference that stuff.
That comes up, that doesn't come up much in the book, actually. I think initially I thought a lot about, so I thought, well, you know, the universal versus targeted dimension mattered because in general, the policy feedback literature has found, for example, that targeted programs like TANF, right, this is what Joe Sauce finds, have a negative effect on political participation, whereas the universal programs, like my colleague Suzanne Mettler, who's looking at the GI Bill, or Andrea Campbell, who's looking at Medicare. And so there are a couple things. One is that like the policy feedback literature as it moved forward became much more complicated than that. So for example, Sarah Burke and Joe Sauce and colleagues found that, you know, public housing doesn't seem to fit into that, or not public housing, but Head Start doesn't seem to fit into that dynamic because they find positive feedback effects for Head Start even though it's means tested, right? And so I started off thinking maybe this is a means tested, not means tested thing, and I still think that matters. I certainly think that matters. I don't think that's the kind of like major crux, especially because the middle class people that I interview who are not getting Medicaid because of any kind of means testing, they're not getting it because they're poor.
But they're getting the stigma.
Yeah, well, yes. So there's certainly stigma with Medicaid. The thing to keep in mind, though, is that if we look at the Kaiser Family Foundation surveys and we look at other survey data that ask people about Medicaid, Medicare, and then other programs, you know, Medicaid isn't as popular as Medicare and Social Security, but it doesn't look anything like TANF and food stamps. And so the level of stigma, Medicaid is in between, but it's closer. It's actually much closer to Medicare and Social Security. This is why I think when it comes to means tested versus not means tested, stigma versus no stigma, Medicaid isn't actually it's not a straightforward program in those terms. Because the public opinion suggests to us a lot of people understand Medicaid in positive terms. You know, 1 in 5 people are utilizing Medicaid themselves. Many more have a close friend or family member. Medicaid isn't stigmatized in everyone's mind. I think that part of what's happening now is a systematic effort to make Medicaid look more in the public mind like TANF does, right? So let's drug test them, let's work requirement, and that just creates that association. But I don't think that is long-standing. I think that's being produced by the political process as we speak.
Well, Jamila, we could sit and listen to you all day.
And I could
It's
talk
been
to
so
you all
fascinating,
day.
but we have to end here, and thank you very much.
Thank you.